Cardiovascular disease is very common and it's very serious. It kills more people in the world and in the UK than anything else. It costs the NHS £11 billion a year, and 200 people a day die of a heart attack, which means from the start to the end of this video, around 2 people in the UK will have died of a heart attack. I work in interventional cardiology where we treat patients with coronary artery disease. And one of the challenges we face revolves around decision making. Traditional clinical assessment methods are good, but most of them are very invasive, which mean that we have to put tubes and wires inside people's hearts. And also they only yield a certain level of information which we can use to make decisions. The majority of patients with coronary artery disease that we treat will receive a stent. That's a small tubular metal scaffold which splints open the artery and allows blood to flow into the heart muscle. Now, there are a few problems with stenting that we need to overcome. First of all, we have to decide when it's appropriate to put a stent inside a patient's coronary artery or do surgery. These are big decisions for a patient. We have to decide how many stents to put in, where to put them, how best to deploy them. And also, the design of those stents is also very important. We have to make sure we design stents really well so that blood clots, atherosclerosis and coronary disease don't block the arteries back up again.
Arteries take blood from the heart to the lung, where the blood becomes oxygenated. It's then returned to the heart, and then other arteries take the blood to the rest of the body in order to supply those tissues with nutrients and oxygen. One of the important diseases of arteries is called atherosclerosis. This is driven by a number of risk factors, including aging, gender, so men are more likely to get the disease, smoking, obesity, and cholesterol, fatty foods. And in this disease, the arterial wall gets thickened because of the accumulation of fats and other materials. And so the lumen of the artery, which takes the blood, gets reduced, and therefore the blood supply to the tissues is reduced. And this can lead to very important catastrophic consequences, including heart attack and stroke. Atherosclerosis is a very complex disease, and there are a lot of components of the vessel wall that are going wrong in that process. For example, some of the bad genes get switched on during disease and some of the good genes get switched off. Another example is that complex blood flow can change the cells in the arteries to behave differently, and that can lead to a disease process. In my lab, we try to understand these processes in great detail, and then if we can do that, we can think of new treatments. So for example, we might be able to find a new drug that can reduce the activity of a bad gene and therefore treat the disease.
My interest is in silico modelling of the cardiovascular system, and specifically the application of this approach to the understanding of medical device design and the response of the biological system. A good example of this is shown in the images here. This is a coronary stent, which is used to treat patients with cardiovascular disease. The issue with coronary stents is that the geometry is rather small, so typically the diameter of the stent is around 1 to 3 millimeters. This makes it challenging, if not impossible, to study these devices in detail using experimental methodologies. And so what we can use is in silico techniques and modelling techniques to understand the detailed features of the flow around the stent, for example. If we combine this with a detailed understanding of the response of biological systems to this physical environment, it gives us a deep insight into the way in which biology behaves, both in the normal conditions in healthy individuals and in the presence of disease. Whilst the models that we currently have are state-of-the-art in terms of their representation of the physics of these systems, what's lacking is the representation of the biology within these in silico models. So if we can improve our understanding of the biology and then integrate that within the in silico model, we believe that that will give us a much better understanding of the response of the biological system. And ultimately, this will lead to improved patient care.
The in silico techniques we're working on in Sheffield, for example, will allow us to do lots of the assessment work for patients with coronary artery disease less invasively, so we won't have to put catheters, tubes and wires inside patients. We can base those on imaging techniques. But also, we think these new techniques will help us to yield more information, helping us to make better decisions about how and when to treat. Ultimately, my hope is that the models that we're developing can be coupled to other models of the cardiovascular system, models of different length and time scales, models right down to the molecular or cellular level, and all those models can be coupled together so that we can simulate cardiovascular physiology, disease and medicine on a much grander scale, which ultimately will help us to overcome even bigger challenges in cardiovascular disease.